She's a clinical assistant professor of pharmacy practice at Campbell University. She's an internal medicine clinical specialist and the program coordinator for the internal medicine PGY2 residency at Duke Regional Hospital. She graduated with a doctorate of pharmacy from West Virginia University and completed a PGY1 residency at St. Clair Regional Medical Center in Moorhead, Kentucky. She's been everywhere. Dr. Wente is an instructor in the Campbell PharmD and PA programs as well as the Duke PA program. Her research areas of interest include anticoagulation management, neurology, nephrology, inpatient diabetes management, and educational principles and practice. She is the course master for a neurology elective and offers research opportunities for P3 and P4 students. She enjoys being involved in interprofessional education and is an active member of several committees on campus. Her writing credentials are incredibly impressive, so I definitely invite you all to take a better look at her. I'd like to welcome Dr. Wente.
Thank you, Roxanne. I appreciate it. She said, let's do something that's, diversity, equity, inclusion related, or I really wanted to go kind of a public health route, but talk about some drugs also. And so this is something that I'm really excited about and excited to talk to y'all about because it's Pride Month. Happy June. And also I serve in one of my many hats. I serve as the faculty advisor for our Pride in Healthcare group, which is for our whole college. And then I also teach a multicultural health practices and health disparities elective. So I kind of have a public health heart, even though I don't have a public health degree. And as internal medicine, I'm kind of a jack of all trades, so I get to run around and do whatever I want, basically. So that's why I wanted to talk to y'all about proactive protection, understanding PrEP and PEP. I'm especially excited about this because there are a couple of new medications that have come out, so I want to talk about those, but I want to talk about what we have overall. And so we're going to differentiate between PrEP and PEP as far as indications, timing, regimens, and monitoring, and talk about social determinants of health, and identify appropriate candidates for PrEP, and determine when PEP is needed, depending on STI exposure, and we'll talk about some scenarios, and then talk about evidence-based initiation and monitoring for patients getting PrEP and PEP. So I really wanted to give a shout out to Samantha. I was super excited that she was presenting on HIV medication access and adherence yesterday, and so I think this fits in really well as far as looking at the preventative aspect, and there are some access issues that come with this as well. So we'll talk about those a little bit also. So, don't look at that one. So how many of y'all are raise your hand if you're from the West? Okay. Midwest? I figured. And then Northeast? And the South? Okay. So I'm from the South, being in North Carolina and from West Virginia and having spent some quality time in Kentucky as well. So the reason I ask is because it's estimated as far as HIV infections in the U.S. by region in 2022, which is the most recent data that we have, that nearly half of the new HIV infections were in the South. So that's where we're having, most of the new infections. And so that's something that we want to, really think about as far as when we're thinking about regionally, what areas are probably being underserved. And this is actually one of the other reasons that I wanted to give this presentation. So I practice in a rural hospital just down the road from our school in Buies Creek, North Carolina, and I round with a teaching team. So it's all of us, there's a lot of us. We probably need our own theme music. So our hospital's small. It's 50 beds. And we do have an ICU. It's 8 beds. We are the first point of contact for a lot of folks in remote counties. And so we actually have a pretty high acuity and see some things that I had not seen practicing at larger hospitals, which has been really interesting. But there was something sad that I saw within the past 12 months on service. We had a patient who was a 30-year-old woman who had come in with basically heart failure. And nobody knew why this 30-year-old woman had heart failure. And she was a 30-year-old Black woman who seemed by all intents and purposes to have been minding her own business. Nice lady. And we left on Friday. My students and I left on Friday. And when we came back on Monday, it turned out that she was HIV positive. And that's what had happened. She had HIV-related cardiomyopathy. I looked at our attending and I said, how did you even figure this out? And he said, well, we ruled everything else out. And so I just sent HIV testing just to see, and it came back positive. So needless to say, this lady was very upset and did not know what happened. But, just our point was, moving forward and making sure that she got the care that she needed. And so just understanding that access to care is a challenge. What do you think may be some of the other challenges for people getting PrEP or PEP? As far as, why does the South have this disproportionately high rate of new infections?
Is it because it's like I'm being from the South, is it because of like the rural area and the more exposure because of like the drug use?
Yes. So talking about the rural area, more exposure to STIs and infections because of illegal drug use. Like we do have a pretty significant drug problem in West Virginia, where I'm from, in North Carolina, where I live now. And so, we've got this IV drug use issue, but we've also got this access to care issue as well. And so you put those together and it really does, create the perfect storm for something like this. So yes. Any other reasons? Yes.
Just like lack of knowledge or lack of education.
Right, so lack of knowledge, lack of education, health literacy issues, access to care, lack of awareness that HIV is even preventable like this. So that's a big thing, like thinking about the fact that does anybody know that you can take a pill every day or you can take a shot every 2 months or every 6 months and that's going to prevent transmission of HIV? A lot of people just don't know. And then also the stigma. So when we think about HIV, who do we typically think about as the population who are most likely to contract HIV? LGBTQ plus population, men who have sex with men, also IV drug users. But to be real honest with y'all, the LGBTQ plus population has more awareness because they really had to own HIV. And so there's more awareness, whereas, in the heterosexual population, it's kind of like, that's not going to happen to me, potentially. And so, in my experience with, working with my students, working with LGBTQ plus groups, and experience as an ally, the awareness is there in those communities. It's in our other communities, like in our church communities, because as you can see, we're also in that, Bible Belt, Stroke Belt, all of those other belt places. There's a lot of stigma. And so people, even if they are engaging in higher risk activities, are not seeking protection because they feel like there's a certain amount of shame associated with that. So just understanding that nearly half of these new infections were in the South. So being aware that that's the area that we need to target. So why should we care? So it's estimated that HIV transmission in the United States in 2022, there were 31,800 estimated new infections, and of those, 67% were among gay, bisexual, and other men who reported male-to-male sexual contact. 22% were among people who reported heterosexual contact, and 7% were among IV drug users. However, transmission rates are rising in these other groups, and I'm going to talk to you about some of the subgroups that are having a disproportionately high rate of HIV transmission. So when we talk about PrEP, it was initially studied and targeted towards men who have sex with men, but transmission rates are rising in these other populations, and so we really need to increase awareness in these other populations. So when we look a little bit deeper into the data, about 1.2 million people in the United States are living with HIV, and about 1 in 8 of those people don't even know they have it and need testing. So there's a lot of lack of awareness there, which of course means these people aren't being treated, which means that there's that increased risk of transmission there. HIV disproportionately impacts racial and ethnic minorities, people who are below the poverty level also, gay, bisexual, and other men who have sex with men. And so this is a diversity talk. It is about underrepresented minorities. It is about people who are socioeconomically disadvantaged, because those are the people who are most at risk and need the most intervention and awareness. So the CDC estimates that new HIV infections have decreased 12% between 2018 and 2022, and there's been a significant decrease in people aged 13 to 24. So our younger generation are having increased awareness and probably a better uptake of PrEP in that population as well. So probably due to the increases in PrEP, better viral suppression overall, and HIV testing. So those are some of the things that are going to, really help decrease transmission. One of the things that really, like the first time that our infectious diseases specialist that I work with at Duke Regional, first of all, infectious diseases is not my happy place. So it's kind of funny that I'm giving an infectious diseases talk, but this is something that's more of a public health thing for me, and so that's why I really care about it. But, viral suppression. And so our infectious diseases pharmacist, he said, can't see it, can't spread it. I said, whoa, why doesn't everybody tell? Why isn't that, just like out there? Why aren't we telling everybody that? So viral suppression is really important, because if your patient has an undetectable viral load, their risk of transmitting HIV to someone else is very, 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 very low, probably 0%-ish. So prevention and treatment identification are really, really important. So hopefully the rate of new infections and this decrease is due to those sorts of things, because we are testing more people. So we do screening like for pregnancy. Everyone who's pregnant gets an HIV test regardless. And so that has helped with, mother-baby transmission and things like that. And so other reasons why we should care. So when we look at the race and ethnicity data from 2022, people identifying as Black or African American accounted for 37% of the estimated new infections. People identifying as Hispanic and Latino accounted for 33% of new infections. And the people identifying as white accounted for 24% of new infections. So when you do the math, 37 plus 33, 70%. So overall, 70% of new HIV infections occurred in minority populations. So we need to increase awareness about that. And then with the age-related statistics, so we said that folks aged 13 to 24, there was a decrease in new infections. And people aged 25 to 34 were the largest number of new infections. So that next generation up, so 13 to 24, big improvements, but that next set up, the 25 to 34, was an increased prevalence of new infections. So understanding that, that's another population that we need to be targeting and increasing awareness. So, and then with sexual orientation-based data, people reporting as MSM accounted for 67% of estimated new HIV infections. However, the annual number of HIV infections among men who have sex with men has decreased 10% in 2022 compared to 2018. So that is decreasing. People who acquired HIV through heterosexual contact accounted for 22%. Men were 6% of estimated new infections among heterosexuals. So these were men who only had sex with women. And then women accounted for 15% of estimated new infections among heterosexuals. So, thinking back to that patient that I saw who was minding her own business and came in with heart failure, and it turned out she had HIV. So the annual number of HIV infections among people identifying as heterosexual decreased 11% in 2022 compared to 2018, but understanding that this also disproportionately impacts women. So now, who are we serving? Like, who are our candidates for PrEP? So this is pre-exposure prevention of HIV. So basically, the short version is anybody who asks. You don't ask any questions. If someone comes into the doctor's office and says, hey, I would like to get on PrEP to prevent transmission of HIV, you just give it to them. Honest to goodness. Like, that is what the guidelines say. Yes, there are people who have been identified as higher risk, but basically if somebody walks into a prescriber's office and says that this is what they want, you give it to them. That's how that works. So everyone is a candidate for PrEP. Anyone who asks is a candidate for PrEP. But when you look at the CDC, they talk about people without HIV who may be exposed either through sex or IV drug use, but you need to inform all sexually active patients at annual checkups, STI treatment or screening. So this is one of those places for intervention where you see someone who's coming in to get medication for a sexually transmitted infection. And so being able to talk to them about PrEP, talk to them about PEP also, which we'll talk about in a little bit, and people who are getting PEP, talking to them about PrEP also. So those are the high yield populations, but the bottom line is everybody is a candidate. Anybody who asks should get it. Like, you don't even need to ask them any other questions. Just give it to them. So what are our options? So as far as medications for PrEP are concerned, there are 2 daily PO options, and we're going to go into those in a little bit more detail. There are also 2 IV options, which is one of the reasons why I was super excited to talk about this. And the IV options are every 2 months and every 6 months. I'm going to tell you a little bit more about logistically how those work as well. So we were talking about this in my elective. I teach my elective in the fall. So we have like an LGBTQ plus day, and we have a panel discussion, and we talk about a lot of things. And so one of the things that we talked about this time was PrEP and access to care. And one of my students who identifies as gay said one of the problems that he was seeing in our community, because we are in a rural area, is that people were coming in with prescriptions for PrEP and they don't carry those medications. And so somebody else piped up and said, well, all you have to do is send your prescription to Amazon Pharmacy and they'll send it straight to your house and you don't have to look at anybody. So talk about a loophole, especially, and that was good for my students to hear because they're going to be healthcare professionals. And so, as a pharmacy technician, as a pharmacist, as a pharmacy student, sometimes you like a little bit of confidentiality about what medications you are on yourself personally. And sometimes that can be hard to find. And so having that other student pipe up and say, oh, you can have your prescription sent to Amazon Pharmacy and they'll send it right to your house and you don't have to look at anybody. It's like, oh. So something to think about for all of us as far as reducing the stigma, increasing accessibility, and getting patients to be more comfortable with getting access to medications. So that's something to consider when you're having a conversation with someone and they're like, well, I just don't know if I want to do this. What if people find out? Or just, all of those sorts of things. That could be a nice option for increased confidentiality. So I have not met any of the drug manufacturers for these drugs. You've seen our HIV meds. The generic names are kind of unwieldy, so I am going to talk in brand names, which, typically in healthcare we do not. Like, we speak generic. In pharmacy we speak generic, and our prescribers and physicians and things tend to speak in brand. So I am going to speak in brand. And so the first drug that I'm going to talk about is Truvada. And so this was approved in July 2012 for PrEP. It is also an HIV medication. It is approved for everyone. So I'm talking about FDA approval. So Truvada is FDA approved for everyone, men, women, everybody. The things that you want to think about as far as monitoring with Truvada are like renal issues and bone issues. So osteoporosis with longer term, really osteopenia with longer term use. But when you stop it, that will also halt. And then checking renal function. So it is contraindicated for folks who have creatinine clearance less than 30. So you don't have as much wiggle room with renal function. And you want to check your patient's kidneys every 6 to 12 months on this medication. It can decrease LDL. And the good news is it's available as a generic. And so this is the drug that we have the most data on. It's been out there for the longest of the medications that we're talking about. It's available as generic. And another thing that I heard about from listening to a podcast as I was preparing for this was you can actually do PrEP on demand. So that was something that I learned while preparing this talk. So typically you take it every day, like once a day, every day. But you can do PrEP on demand. So for folks who are, not regularly sexually active, they can do 2 pills 2 hours before sexual activity, and then they take 1 pill daily for 2 days after. And then there's also another PrEP on demand scheme where you can do start 7 days before. And in this podcast, their example was, say you're going on a cruise. So you can start 7 days before and then complete it like 48 hours after. So there are some PrEP on demand options for people who are not very sexually active but are going to be engaging in activity and want to be protected. So just to know about that. So that was something new I learned while preparing this talk. And then Descovy, which was FDA approved in October of 2019. It is overall a little bit gentler on the kidneys. It is approved for men who have sex with men, transgender women who are having sex with men. It is not approved for women or for anyone else who might contract HIV through vaginal intercourse. So just to be aware of that, it is pretty much only approved for men who have sex with men, transgender women. So not approved for vaginal intercourse and prevention. So with Descovy, overall, renal function-wise, like you can use it, creatinine clearance. I got those reversed. So creatinine clearance less than 60, you have to be careful with Truvada, and then creatinine clearance less than 30, you have to be careful with Descovy. So you can actually use Descovy for folks who have more significant renal impairment as compared to Truvada. Sorry, I flipped those. And so if your patient has CKD or renal dysfunction, then Descovy is going to be the one that you are going to want to use as far as that's concerned. It does have a few more drug interactions, like things like over-the-counter, like St. John's wort, which interacts with everything, I feel. It's really the drug interactions that everything else interacts with, like St. John's wort, rifampin, anti-seizure medications. So all of those enzyme inducer type things. And so it is still a branded product. So it's going to be a little bit more expensive. The advantages to it, though, are mostly like the renal things, and it doesn't have as much of the bone issues, but it can increase LDL and triglycerides a little bit. You just have to keep an eye on your patient. And it is not approved for women. So those are our 2 PO options. Now I want to get into the IV options, which is why I was really excited to give this talk. So the first one is cabotegravir or Apretude. So this was FDA approved in December 2021. It's basically administered every 2 months, but for the first time, you do it monthly for 2 months, and then you go out to every 2 months. It's actually being studied for an every 4-month dosing scheme as well, but that has not come out yet. So this one, it's interesting. With the injectable ones, they're actually approved and were studied in age 12 and older, so adolescents even. So approved for age 12 and older, weighing 77 pounds or more, so greater than 35 kilograms. And like I said, it's 2 injections 1 month apart and then every 2 months. And this is approved for everybody, which is nice. The biggest issues are injection site reaction, and then maybe headache, nausea, and dizziness. Another thing that you need to be aware of with this medication is it may increase depression. So being aware in patients who have untreated or undertreated depression and just counseling your patient, this may have a little bit of an impact on your mood. Want you to maintain an awareness of that and have a plan. Just keep a watch on that and let your provider know if you're seeing some changes in your mood. but it's not a contraindication. It's just a by the way type thing. And then next, so just approved a year ago, lenacapavir or Yeztugo. I saw a commercial for this like yesterday while we were at the restaurant. Did other people see this commercial? Okay, so saw a commercial for this yesterday while we were having dinner. So it's out there and definitely advertising pretty aggressively. So it was FDA approved in June of 2025, and this is every 6 months. Which is pretty cool and really exciting. And it has the best data in women. So that's one of the reasons why I was excited to give this talk. It has good data in women, including it has been studied in pregnancy and lactation. So that's really nice too. And so as far as logistics, because I was giving this talk, I actually asked my primary care provider, I was like, are y'all giving this in clinic yet? And in North Carolina, pharmacists, like, they let us run around and do a whole bunch of stuff. It's amazing. So we get to do like long-acting injectables. Of course, we're certified to vaccinate. We have test and treat for certain indications as well. We're able to prescribe oral contraceptives. There's a bunch of stuff that we can do in North Carolina, which is really exciting. And so when I saw this come out, I was like, I wonder if North Carolina will let us give this. So I asked my primary care provider, because she knows I'm a pharmacist and we talk all the time. So I said, are y'all giving this in clinic yet? She's like, no, we don't have it yet. And I said, okay, so do you know how it works, or do you know anybody who is providing this? She said, okay, so I asked somebody, because my provider, she's awesome. She was like, I've talked about this. I want to get it in our clinic, but this is basically what you need to do. And she said that they send it with an HIV test, like a rapid test. And so you take the rapid test like in the office, then you get the injection in the office. And so it's not like you go to the lab and then your test results come back and then you come back 5 days later and get the injection. It's all at the same time. So that's how the logistics work for that. And that's what I learned from my provider. So the clinic that I go to does not have it yet, but she said that one of her colleagues at another clinic was working on getting it. But just like logistically, it's probably something that your clinic is going to have to be like dedicated to, like it's going to have to be intentional about. It's not like it just shows up and you give it. And it does have to be administered by a provider. So that's that. I'm going to speed up a little bit. So just to kind of summarize what's going on in PrEP, of course, HIV testing first, baseline renal function. Here's my little note about creatinine clearance. So Truvada, creatinine clearance greater than or equal to 60. Descovy, creatinine clearance greater than or equal to 30. So a little bit more forgiving on the kidneys. You want to test again if your patient develops any other STIs. So gonorrhea, chlamydia, syphilis, you want to test for all of those things. And also, if your patient has hepatitis B, understanding that they can be on PrEP, it's not a contraindication, but if they stop PrEP, it could cause a hepatitis B flare. So counseling your patients on that. So just to kind of speed up our time, I'll go to my last what would you recommend slide. And kind of go through some scenarios where you would be able to identify someone who potentially would be a good candidate for PrEP. So based on what I've said and where you practice, or just thinking about, pharmacy in general, who are some of the people that you might be able to create an awareness about PrEP? Like if you're working in a community pharmacy.
I know for me, like the particular pharmacy I work in is within a clinic, and like our patient population is primarily like people in recovery, so those IV drug users. Mm-hmm. So we also do a lot with like Hep C and things like that. So like a good chunk of like our patient population would be really good, for the HIV awareness and testing and PrEP and everything. Mm-hmm.
Absolutely. So a patient population of IV drug users, especially if you're in a rehab clinic, like that is a really good example. So that would definitely be a place where you could increase awareness. Where else, y'all? So if you're filling a prescription for someone who, or someone has picked up Plan B, and so they're doing like some sort of, after intercourse contraception, which would maybe indicate that they were concerned after having unprotected sex, that might be a good person to talk to about PrEP or PEP, and having a conversation with them, and just asking, well, did you know that there are other things that might protect you, not just from pregnancy, but also from infections? And would you be interested in some of your options around infection protection? And so being able to say it in that way, and it's really important to be non-judgmental. And so being able to say, I see that you're getting this, to protect yourself from pregnancy. Would you be interested in other medications that might protect you from infections? And so that would be a good way to broach that subject. Also, one of the things that Roxanne and I were talking about yesterday was the uptick of sexually transmitted infections in the elderly patient population. So this is a thing. One of my girlfriends, her parents lived in the villages, and I heard lots of stories. There's a whole lot going on there. I used to work in geriatrics, and spry old men are a hot commodity because women in general tend to live longer than men. So, if you're a healthy old man, the ladies are coming for you. These widows, they have no shame. They have no chill either. So, so we think about this uptick of STIs in our geriatric patient population because, they're in these communities. They're having sex, they can't get pregnant, so they don't feel any need for condom use or any other protection or STI prevention. And so there is an uptick of things like gonorrhea, chlamydia, syphilis, and then HIV tends to run around with those types of things. So that's another patient population that you would want to be thinking about, even though that could be an awkward conversation. Anybody who's coming in for STI treatment, and another group that we look at, anyone who's engaging in higher risk sexual activities. So a patient with one or more partners who doesn't know the HIV status of their partners, serodiscordant couples. So one person is HIV positive and the other is not. That's a good opportunity for PrEP. Anyone who is having unprotected sex, basically. And one of the things that kind of blew my mind as I was getting ready for this presentation was that the other population that they identified, which is another reason why I asked y'all who's in the South, is people having sex in a geographic area or sexual network where there's a higher prevalence of HIV. So for those people, even if they are engaging in low-risk behavior, because there is an increased chance of encountering people who may have HIV, they also need to maintain an awareness. So I thought that was really interesting. So do y'all have any questions about pre-exposure prophylaxis before we move on to post-exposure prophylaxis, which I'm going to be a little quick about? Mm-hmm. Yes.
No question necessarily, but with the Yes2Go, I just thought I would mention there's the oral lead-in for the Yes2Go as well. Mm-hmm. And what we're finding in our clinic a lot is that medical insurance will cover the Yes2Go injection, but not the oral lead-in. So then they try to get the oral lead-in through pharmacy, and the pharmacy benefit doesn't cover it either. So they're approved for the injection, but not the oral lead-in on either side. And so our clinic is getting really creative with being able to, a lot of the times we see the patient transition from Apritude to the Yes2Go, and they're basically pulling the patient in mid-cycle through their Apritude to start them on the Yes2Go to avoid the oral lead-in that maybe didn't get approved by insurance.
That's really interesting. Thank you, Samantha. So basically what you're saying is, there is an oral lead-in for the Yes2Go, and insurance is not covering that. They're just covering the injectable. And what I read was the injectable, cash price is $28,000 a year. And so you're saying that you're kind of bridging people with Apritude, basically?
They're getting really creative in the clinic.
Mm-hmm.
Trying to transition people without potentially having lapses in their
Mm-hmm. That's interesting. Thank you. Okay. Anything else, y'all? Yes.
What about then with the Cabenuva then? Is that just too new that it's not much information about that for it, or?
There's not that much information about that as far as PrEP, but for treatment is is where it's indicated. And I don't know if they're pursuing a PrEP indication or a PEP indication or not, but yeah, it's mostly for treatment. Any other questions?
It seems to me that spring breakers certainly get a lot of Plan B when they come in.
Okay, so maybe those spring breakers need to be on that like on-demand PrEP. Like that would be a really good example of, okay, you take it for 7 days before, and then you get off a spring break and you take it for like 48 hours after. So that would be a good place to recommend like the on-demand PrEP then potentially. Good thoughts. Okay. Oh, yes.
I'm so
go
sorry.
ahead.
I did have just one little quick question that stuck out. You were talking the injections IV. Our clinic gives them IM.
Oh, I'm sorry. It's
You're okay.
IM.
I
That
was
was just
like, did I miss something?
No, that was my brain. Because I'm a hospital pharmacist, like IM is not a thing that like quickly rolls out of my mouth. That is what that is. But no, it is IM, and either the stomach or the arm or the thigh. Yeah. Thank you. Yeah, I just don't say IM very easily. So talking about PEP, so post-exposure prophylaxis. So I want to speed up a little bit so that we are good on time. So basically, post-exposure prophylaxis is a medical emergency. You need to be able to start treatment within 72 hours because studies show that the efficacy of treatment nosedives after that. So it's not like your patient or as a healthcare professional, you end up with an exposure and you have time to wait to get HIV tested and for those results to come back before you start medication. Like you need to start within 72 hours, ideally within 48 hours. And so when we're talking about post-exposure prophylaxis, we're talking about sexual contact, unfortunately including sexual assault, needle sticks, IV drug use, and also mucous membrane exposure, which is another way that we as healthcare professionals can accidentally get exposed. So those are some of our risks, like needle exposure and needle sticks, but also mucous membrane exposure. Like say you're going to a code or you work in the ED and you don't have a face shield on and you get some sort of like mucous membrane exposure that way. So exposures that have fewer risks, less risk, contact with intact skin, saliva, sweat, or tears, needle sticks that don't involve a person with HIV or increased risk. However, you really don't have time to, like a lot of times you don't have time to figure that out. So understanding that post-exposure prophylaxis is another one of those things where it's a shared decision making, and if somebody asks for it, like, give it to them. Do y'all have any experience or things that you want to talk about as far as post-exposure prophylaxis from like a healthcare professional standpoint or anything like that? So I think, definitely for our colleagues who are in direct patient care, for us, like we do a lot of vaccines, but not as much of an issue there as well. But understanding that it is a medical emergency, time is of the essence, and basically the medications that we're using, there's a 2-pill regimen, which is basically Truvada plus either Ascentris or Tivicay, or Truvada plus 2 protease inhibitors to get the boost. Or you can do Biktarvy as a 1-pill regimen, which seems pretty convenient. And that's kind of a newer thing that wasn't even on the CDC website for some reason. So those are your options. So if you want 1 pill a day, the Biktarvy, and then otherwise there's Truvada plus an Insti, or Truvada and 2 protease inhibitors so you get the boost. And treatment's like 28 days. Basically. And so what you'll do is you'll treat for 28 days and then you'll test after that. And the other thing that you want to think about is like a PEP to PrEP transition for folks who, would be candidates for PrEP. When they come in for PEP, you do their PEP and then you transition them to PrEP. So those are some of the things that you're going to want to be thinking about. We talked about oral regimens and timing, so understanding that there's 3 different options. Biktarvy is the newest, and that's a once a day. But really, like time is of the essence. You need to start it within 72 hours, or else it's not going to be effective. And then I want to take just a second and talk about PrEP. So this is not for HIV. This is for syphilis, chlamydia, gonorrhea. And I'm from North Carolina, and I moved to North Carolina from West Virginia. And within my first week of rounding at a major urban hospital in North Carolina, in Raleigh, I saw neurosyphilis. I'm texting my friends, I'm texting my neurologist friends, I'm texting my regular medicine friends. I'm like, I saw neurosyphilis today, y'all. They're like, what? And so I was, talking to our attending. I was like, I've never seen neurosyphilis before. I've rounded with neurology. I've rounded with internal medicine. I'm infectious diseases adjacent. I have never seen neurosyphilis. And this was, I was like 6 years out of school. So still pretty new. And the attending said, oh, well, North Carolina is, we have a high prevalence of syphilis. And so people who study syphilis come here to study it. North Carolina is full of syphilis. And it turns out that a lot of that is because of the Tuskegee experiments, where they allowed people to contract syphilis and didn't treat them, and then just watch to see what happened. And this was primarily Black males. It happened up until the late 1960s. And so that's why we're still seeing this in our patient population. I have seen more syphilis in rural North Carolina than I would have ever dreamed of. So it's out there for us. And then, again, back to this whole STI transmission in the South. So PrEP has found to be most effective for men who have sex with men and transgender women. That's who we're studying things in. There's very limited data in cisgender women, as with most other things. But it's doxycycline, 200 milligrams PO times 1. Again, within 72 hours, preferably within 24 hours. It can be taken every day, but not more than once a day. And so this we can do to prevent gonorrhea, syphilis, chlamydia. And then, of course, the rules with doxy. Don't take, separate it from calcium, dairy products, antacids, et cetera. Going to cause some GI upset potentially, and then increased risk of sun sensitivity and sunburn. So just to kind of summarize the things that we want to talk about with PEP, just identifying your patient population and understanding that time is of the essence. You want to start within 72 hours for all of our PEP regimens, whether we're preventing HIV or other STIs, and understanding that this is another area where if people ask for it, give it to them. And the folks who are going to be at highest risk are people who have unprotected sex, people who are victims of sexual assault, IV drug users, needle stick, mucous membrane exposure. Those are the folks who are going to be at highest risk. And so I want to go to our just a quick little recap so that we finish on time. So when we think about pre-exposure prophylaxis, those are people who are HIV negative, who want to prevent HIV. So it's anybody who asks, again. And then the timing this is going to be something that your patient takes daily. There are some on-demand PrEP options that we talked about as well. And then post-exposure prophylaxis, you need to start it within 72 hours for anyone who has potentially been exposed to HIV. And then also we have the PrEP for gonorrhea, chlamydia, and syphilis. And then our regimens for PrEP, we have the 2 daily oral regimens, the Truvada and the Descovy. And there's, again, that on-demand option with the Truvada. And then we have the 2 IV regimens, one that's every 2 months, and then the other one that's every 6 months. But again, with the PO lead-in, with the Yes2Go, which apparently is a challenge. So that's interesting to find out, and the ways that y'all are working around that. So really, those were the things that I wanted to talk to you about. Just thank you for your good questions and your participation. But